So finally, we have the diagnostic criteria to tell whether it's a DK or HHS. To tell it's a DK, you need a triad. That is, you should have hyperglycemia, that is more than 200 is enough, and there should be a ketosis defined as plasma beta hydroxybutyrate more than 3, and there should be acidosis defined as venous pH less than 3 or serum bicarbonate, venous bicarbonate less than 15. Now let us see the differences between DK and HHS. The first difference is comparing the what type of diabetes that produces DK and HHS. Remember, type 1 diabetes mellitus very commonly produces DK. In fact, highest risk of developing diabetic ketoacidosis with type 1 diabetes mellitus only. In fact, type 1 diabetes mellitus children usually present with DK for the first time. For the first presentation itself will be DK most of the times. And who are DK prone? Type 1 diabetes mellitus patients. And incidence of DK is extremely high with type 1 diabetes. But the most common cause of DK in the world is not type 1, it is actually type 2. Even though less than 5% of the type 2 diabetes mellitus patients develop DK, only in the late stage they develop, but they never present usually with DK. Only in the late stage they are going to present with DK because of insulopenic stage. But because of the sheer number of type 2 diabetes mellitus cases we are seeing in the public, and the type 2 diabetes mellitus is grossly more prevalent compared to type 1, even though the incidence is less with type 2, but the most common cause of DK is actually type 2 diabetes mellitus patients only because of the total number of type 2 diabetes mellitus that is present in the community. Whereas HHS is usually a complication of type 2 only because there is some insulin here. So definitely some insulin present is not a feature of type 1 at all. So it must be a type 2 diabetes mellitus. And will there be any precipitating cause? There is no difference in that. Precipitating cause can be seen in both DK as well as HS, like infection and surgery. So that's not a difference. The next difference comes in the level of dehydration, where we know that HHS patients tend to be more dehydrated compared to DKA. That's why I'm putting 2+. If you want to compare, DKA patients tend to have approximately 6 liters of fluid loss, which is roughly equivalent to 5 to 10% of their fluids, whereas HHS patients tend to lose approximately 9 liters as an average, which is roughly equivalent to 10 to 15% of the total fluid in the body. And comparing the sodium loss, we know it's going to be more, and electrolyte loss as a whole is going to be more with HHS compared to DKA, where the sodium loss is approximately 6 to 10 millimoles per kilogram in DKA patients, whereas it is approximately 5 to 13 millimoles per kilogram in patients with HHS. It's slightly higher in HHS. And what about the potassium loss? Potassium loss once again is going to be a little more with HHS, whereas potassium loss in DKA patients is going to be 3 to 5 millimoles per kilogram, whereas in HHS it's approximately 4 to 6 millimoles per kilogram as an average. And there is going to be phosphate loss as well. Phosphate loss can be almost equal between them, where it is approximately 5 to 7 millimoles per kilogram, whereas in HHS it's 3 to 7. I can write 5 to 7 millimoles per kilogram as well. It's almost equal. Even though phosphate loss is little similar, we know that phosphate less than 1 milligrams per deciliter is a very high risk for developing rhabdomyolysis in these patients, especially adult patients with HHS and children with DK less than 20 years, high risk of rhabdomyolysis, especially when they come for the first time. Rhabdomyolysis risk is a little higher with HHS, even though there is no significant difference in the phosphate loss in these patients, still a little higher with HHS compared to DK patients. And what about the abdominal pain in these individuals? Abdominal pain is a feature of DKA, very unlikely to happen in HHS. And encephalopathy can happen in both, even though the risk of encephalopathy is more with HHS because of the hyperosmolarity, which is more in HHS patients. And what about the fruity odor in the breath? That is a characteristic feature of DKA, not a feature of HHS at all. What about hyperventilation, tachypnea and shortness of breath? Once again, characteristic feature of DKA, not a feature of HHS. And if we see the serum glucose, now coming to the biochemical parameters, serum glucose more than 200 is sufficient to diagnose a DKA, but according to the diagnostic criteria, but usually it will be in the range of 300 to 400. So that's the usual range of serum glucose in a DKA. It usually does not exceed 500 because it's a very acute process. Patient comes very fast to the hospital. That's the reason. Whereas in HHS, it will be usually more than 600. To produce that much hyperosmolarity, you need a very high glucose. That's why it comes subacute. It takes a long time to reach that 600, 700 level. But usually the glucose will be in the range of 800 to 900. Criteria wise, it's more than 600. But usually they will be presenting with a sugar of 800 to 900. And what about the plasma ketones? Remember, you have to do plasma ketones for safety, not urinary ketones. Plasma ketones will be either 3 plus or 4 plus if you do qualitative analysis, or you can also tell the beta hydroxybutyrate levels more than 3 millimoles per liter or 30 milligrams per deciliter according to the guidelines. So if it's more than 3, significant elevation of beta hydroxybutyrate is needed for development of diabetic ketoacidosis. Similarly, here there will be no ketones. They can be either negative or only trace positive. So usually by definition, the beta hydroxybutyrate should be less than 1.5 in a patient who is suffering from hyperosmolar hyperglycemic state. There should not be significant ketosis and there should not be significant acidosis as well to diagnose HHS. So which means I have to know the serum bicarbonate, which will be usually less than 15 in the setting of DKA and more than 15, not much acidosis in the setting of HHS. And anion gap by definition usually will be more than 10 in the setting of DKA because it's a high anion gap metabolic acidosis. By definition, HHS will have less than 10, normal anion gap. And there is no acidosis. And pH, arterial pH or venous pH. Usually we do in the venous blood itself because we don't want to puncture the arteries usually in a patient with a DKA. So in this setting, pH must be less than 7.3, confirms acidosis. It will be more than 7.3, telling it's not acidosis. So finally, we have the diagnostic criteria to tell whether it's a DKA or HHS. To tell it's a DKA, you need a triad. That is, you should have hyperglycemia, that is more than 200 is enough, and there should be a ketosis defined as plasma beta hydroxybutyrate more than 3, and there should be acidosis defined as venous pH less than 3 or serum bicarbonate, venous bicarbonate less than 15. So that's why it is called a diabetic ketoacidosis. So just having hyperglycemia without any evidence of ketoacidosis, you cannot take it as a DKA. That's a common mistake done by the practitioners. They think patient having 400 glucose, having a trace positive ketones means DKA, admit the patient in ICU, start insulin infusion. That is absolutely wrong. You should not do that. You can treat that patient in the OPD itself. Even they have a glucose of 400, 450, it's okay, treat them in the home. They are not having ketoacidosis. They are compensated. So no need to admit the patient. You can just give insulin and ask them to take treatment from the home itself as an OP basis. You can dispose the patient. Not a problem. No need to admit them. Ketoacidosis is what the problem that brings the patient to the hospital in this setting. So that's why you have to admit them. Clear? Similarly, how will you diagnose HHS? Again, you can put a triangle. Here the glucose level should be extremely high. That's a rule because without such a high glucose, you cannot develop HHS. Hyperosmolarity. So more than 600 by definition, it will be usually in the 800, 900. I have seen 1400 milligrams of glucose as well. And there should be no ketoacidosis. We know that because if there is ketoacidosis, it will go towards a DKA only. So by definition, HHS should not have any ketoacidosis because there is some insulin that can stop the lipolysis and ketoacidosis from happening. So by definition, there should be no ketosis means beta hydroxybutyrate should be less than 1.5 by definition, which means there is no significant ketosis, and the pH should be more than 7.3 and the patient's serum bicarbonate should be more than 15 by definition to diagnose it's a HHS. And number 3, patient should have hyperosmolarity. That's the defining feature of HHS, where the serum osmolality by definition should be more than 320 milliosmoles per kilogram. So, and having known about the differences between DKA and HHS, we have to discuss about the DKA in a slightly more detail because there are some classification systems also.
Subscribe and press the bell icon so you never miss an update from PrepLadder.